course, I would like to thank the ERN network for inviting me to talk about one of my favorite subjects, namely radioiodine. Before we start, I would like to give you my disclosures for a second. And as this year, it's been 80 years since the first application of radioactive iodine in humans for therapeutic purposes, I would first like to start with a brief historical overview. It's been a while. Actually, the history of radioactive iodine started 85 years ago, not 80 years ago, when Dr. Sal Hertz talked to Professor Compton, the president of the University of Massachusetts, and discussed with him the possibility of making iodine radioactive. Now, Dr. Hertz had been researching thyroid physiology, and Professor Compton was involved in the cyclotron at MIT. It took a few months, but in the end, they actually got together and produced radioactive iodine and started a series of experiments in mice and rabbits, especially rabbits, which preceded the therapeutic application in humans by a number of years. So this is the real inception of radioiodine therapy. Now, from 1941 onwards, at the Massachusetts General Hospital, 29 patients were treated who had therapy refractory hyperthyroidism, and they found that they were able to cure 20 out of those. These are the original handwritten tables in Dr. Hertz's lab journal. So these were the first patients treated with radioactive iodine therapy. And as Dr. Hertz and Dr. Roberts already described, in the end, they were able to treat approximately 80% of patients with a considerable degree of success, and only 20% of patients with hyperthyroidism remained hyperthyroid. Now, this is the first series, and it is already remarkably akin to the results that we see in present-day therapy of Graves' disease. If you look at what was given, these activities certainly also range from, shall we say, not even a millicurie to 15 millicuries, which is quite akin to what we give these days. So the question really is, what is new? If this was the first therapy series in benign thyroid disease, what is new? Now, the popular reception was somewhat moderate where it came to benign radioactive iodine therapy. You can see here a local researcher discovers a cure for goiter through A-bomb byproduct. Of course, this was 1946 that all these reports of radioactive substances were actually published. So anything radioactive was kind of associated with the atomic bomb. However, the real positive and popular reception, and the one which actually led to the legislative framework which stood at the basis of nuclear medicine, was the reception that this picture got. This was a critically ill thyroid cancer patient who had metastatic thyroid cancer, who in 1943 was treated at Memorial, what is now Memorial Sloan Kettering in New York hospital, with radioactive iodine. The patient was severely cachectic, he was in pain, and as you can see, over the course of a few years, he certainly improved his condition, which then led to the popular press stating that radionuclide therapy is magic. And while I wouldn't agree that it is magic, I could certainly agree with the very enthusiastic popular reception. So I think it is fair to say that iodine-131 therapy stood at the birth of nuclear medicine. And it is important to know that the basic concepts which are still practiced today in nuclear medicine when treating thyroid cancer patients or treating patients with benign thyroid disease, that these concepts were already present. The first report on thyroid cancer was not only written by a Mr. Seitlin, but equally important by a Dr. Marinelli, who those of you in the nuclear medicine world will certainly recognize from the Marinelli formula. Yes, this was the same Mr. Marinelli. So it should be no surprise that not only did our grandfathers in the field already perform some form of imaging, albeit in a crude form by using a Geiger counter and recording with a cross or a dot on a piece of paper on a schematic drawing where the lesion was, but it still constitutes a form of imaging. And they already performed a form of dosimetry by exactly measuring the cause of radioactivity in the patient. And of course, these same doctors also had a keen eye for the untoward effect, and in 1955 already published the first report on leukemia in a patient repeatedly treated with radioactive iodine. Now, that means that we have a good 6.5 decades of experience with the side effects as well. And I think it is fair to say that iodine-131 constitutes the first true targeted oncological therapy. Just to repeat, radioactive iodine is taken up in a basically the same as normal stable iodine. Through the sodium iodine supporter is transported through the cell to the colloid, and in the colloid, the apical membrane is built onto tyrosine residues to form T3 and T4. Then, under the influence of TSH, this is resorbed and gets excreted in radioactive form, just as it would in non-radioactive form. And the principle of targeted therapy is thus that you can give a medication to a patient either orally or intravenously or in any other form, which is applied in a simple manner, then circulates systemically through the whole bodily fluid, so that it reaches all cells in the body, and then only gets taken up and only remains in the target tissues, so the tumor, the metastases, or in the case of benign thyroid disease, the thyroid. Now, for radioactive iodine, except for a few minor exceptions, this is largely true. More true than for any other targeted therapy that I'm aware of. Now, radioactive iodine has been used for both benign thyroid disease and differentiated thyroid cancer. However, interest has been somewhat differentiated. If you look at the total number of publications that you get if you search PubMed for radioiodine and benign thyroid disease, Graves' disease, goiter, or autonomous nodules, you still do not achieve even 2/3 of the results when you combine those two. Then you would for radioactive iodine therapy and thyroid cancer. So I think it is fair to say that the interest in radioiodine therapy and thyroid cancer considerably exceeds the interest in radioiodine therapy in benign thyroid disease. This is especially reflected in the last few years if you look at what discussion there is and what is new actually. So the majority of this presentation will also deal with thyroid cancer, just for the simple reason that there's more to discuss and there's more in literature. Now, what did make radioactive iodine great? Yes, it was good for benign therapy, benign thyroid diseases, but the true interest has been sparked in radioiodine therapy because it is great for differentiated thyroid cancer. This was especially shown nearly 30 years ago in the landmark study by Malziferi and Yan, who published in 1994 that the recurrence rate and the mortality rate were dramatically lower in patients who received iodine 131 therapy after surgery compared to those, here in the red lines, who did not. And I think the various studies that came afterward, and most notably, for instance, here from the Mayo Clinic, in a large long-term series, also showing that radioiodine therapy significantly and markedly improves prognosis. In fact, for instance, a pediatric cohort from Poland, it could be shown that not receiving radioactive iodine therapy is the single most unfavorable prognostic factor for overall survival, with the exception of having distant metastases at diagnosis. And it can be shown that patients in patients populations who have had radioiodine therapy, that life expectancy is largely normal, perhaps with the exception of those with distant metastases. And if you look carefully at those, it's especially the proportion of patients with distant metastases that are radioactive iodine refractory that caused the decrease in life expectancy. So the life expectancy is here the discontinued dotted lines versus the observed here in a continued but a bit a regular Kaplan-Meier curve. Now, that's history. I guess history, okay, it's good to know where you come from. And of course, it can give some insights where we might be going. But now for today, I would personally like to start with a few words on the few interesting developments in benign thyroid disease. And I think the most pertinent issue still in benign thyroid disease is the dosaging strategy. How do you select your activity to treat a patient? There's always three strategies, and this also goes for thyroid cancer, by the way. There's the empiric activity, basically meaning the physician sucks his thumb, perhaps still looks which way the wind blows, sticks his thumb in the wind, and then thinks, yeah, okay, I think that might work. Or you can do a quantitative dosimetry to deliver an effective radiation dose to a defined thyroid volume, or hybrid strategies which employ any of the two principles in combination. Say, for instance, an uptake measurement and then an uptake related strategy or something like that. Now, especially in Europe, some changes are coming. A couple of years ago, the European Commission issued the Council Directive 2013/59/Euratom. Now, this is all quite legalese, but for radioactive therapies, this has some consequences. Basically, this directive says that all individual medical exposures are justified in advance, taking into account the specific objectives of the exposure and the characteristics of the individual involved. So this means you really have to define what you want to achieve ahead of time. Do you want to achieve euthyroidism? Do you want to achieve hypothyroidism? And you have to individualize your therapy, whether that be based on palpation, whether that be based on full dosimetry or on uptake, is not stated in this sentence. But however, you might get some clarification there from Article 56, stating that for all medical exposure of patients for radiotherapeutic purposes, exposures of target volumes shall be individually planned and their delivery appropriately verified, taking into account that doses to non-target volumes in tissue shall be as low as reasonably achievable and consistent with the purpose. Now, again, this is in nuclear medicine circles subject to heavy debate whether this means you should do full dosimetry or you should just have a look at the patient and say, okay, he's male and he's big, okay, I'll give him 20 millicuries. It's quite possible that, but there is some discussion there. Now, thus far, it has always been the question, is a full dosimetry, is it of benefit? Personally, of course, I do think there is something to be said for it. If you consider that if you give a fixed activity strategy, this would mean, this is an example from my own practice, which made me see that we might have to individualize. We had two patients for the same disease with the same goal lying in two rooms next to each other. The first was an old lady who was 1.55 meters and 49 kilos, so she had 3.5 liters of blood volume. She was old, her kidney function was not as good, so she had an effective half-life in blood of 36 hours. In the other room, we had a young man of, shall we say, somewhat larger proportions. He was 2.10 meters or 7 foot, 200 kilograms or roughly 450 pounds. He had a blood volume of 8 liters and had an effective half-life, because his kidney function was, of course, excellent, being a young man, of 8 hours. And you would give these people the same activity. Now, that would mean that there's a considerable higher concentration of radioiodine for a considerably longer time in the old lady than in the young man. And still you want to have achieved the same goal. To me, that doesn't make much sense. Now, very recently, some interesting data emerged in literature, which showed that for the first time, in a meta-analysis, it could be shown that there actually is a direct relationship between the result of radioiodine therapy and the delivered dose to the thyroid. In individual studies, in individual populations, this never came out, usually because, let's face it, those studies are all retrospective, and there's a considerable selection bias, and there's measurements beforehand, so it really never came out. But if you look at it, there's a clear-cut relationship basically stating that the higher your dose to the thyroid, your delivered dose to the thyroid is, the higher your percentage of patients who are no longer hyperthyroid. But also, the higher your dose, the higher the percentage of hypothyroidism is. And now, what does it show? Conveniently, dosaging schemes targeting at 150, 200, or 300 grays have been around for a long time. And conveniently, yes, if you want to aim at euthyroidism, the optimum lies for a delivered dose appears to lie between 100 and 150 grays to the thyroid. Basically stating that if you aim at 150 gray roughly, that you have an optimal chance of achieving euthyroidism. If you go higher, your rate of euthyroidism will go down because your rate of hypothyroidism will go up. However, with increasing delivered dose, the total success rate, if you consider the vanquishing of hyperthyroidism, of course, goes up. Now, this perfectly illustrates the Euratom directive. You have to first define what do you want to achieve. Do you want to achieve cessation of hyperthyroidism? In that case, euthyroidism or hypothyroidism are equal. Do you want to achieve functional ablation, meaning hypothyroidism, or do you want to have the best shot at retaining euthyroidism? This will then in turn determine your delivered dose, and I think especially this work by Pakroge and Flux and colleagues from the Royal Marsden in London really shows why a full dosimetry of the thyroid can be of benefit if you really want to individualize the goal and the outcome. More exciting news is there is not at the moment for benign thyroid disease. Therefore, I want to switch to thyroid cancer. First of all, terminology, and I want to illustrate why there's a connection with rum in this topic. For the past decades, there has been a confusion of terminology. Words like radioiodine ablation, adjuvant modality, have been mixed and intermingled and been colloquially used without a real true definition and without a real agreement on what they should mean. For instance, the guidelines from the European Association of Nuclear Medicine from 2008 in a single sentence use both ablation and adjuvant in a single sentence together, and as a content define both remnant ablation and the treatment of microscopic tumor deposits, which is again an adjuvant treatment. And this confusion has been present in many guidelines over the past decades and in countless numbers of scientific papers. Because there have been a number of disagreements between major thyroidologically interested societies, the American and European Thyroid Association and the European and American Societies for Nuclear Medicine, a consensus conference was initiated in 2018, 2019, and 2020, held between these four societies to resolve a lot of controversy in the field of differentiated thyroid cancer, which was then held on Martinique in France. Now, Martinique is part of France, but it conveniently lies in the Caribbean Sea and is famous for having a good weather, so that you get a relaxed atmosphere where experts can lay down their suit and tie and instead have a polo shirt and shorts, which creates an entirely different atmosphere of discussion, which means that people are suddenly a lot more friendly instead of having to defend their territory. And of course, there are moderating agents available for which the island is famous, which certainly helps the personal and professional relationships between experts and is a fruitful basis for achieving consensus on the content and topic. So what a consensus on terminology emerged is that all forms of radioactive iodine after given to a thyroid cancer patient are called iodine-131 therapy. This is then further divided into three possible sub-goals. It could be remnant ablation, where your prime objective is to reduce or destruct a sufficient part of a healthy thyroid remnant tissue after surgery to allow for a sensitive thyroglobulin-based follow-up. The second objective could be adjuvant treatment, which is given for the treatment of unknown metastases or micrometastases and for the prevention of local recurrence through destruction of a previously unknown foci. Important is here that you give it for disease that you suspect that might be there, but you do not know for sure. Because if you know for sure, then the next and third objective is the treatment of known disease. Now, there's a lot of discussion about how much radioactive iodine should be given for which of these goals, and should we still do remnant ablation, or is remnant ablation obsolete in the time of high sensitivity thyroglobulin? But this is less directly related to iodine-131 and somewhat more controversial, so that I'm not going to go in there as much. Now, a major question of surrounding radioiodine therapy is, even after 80 years, who in the field of thyroid cancer, which patients, who will benefit? We still don't know. There is a fair consensus that high-risk patients will benefit, but what about the low and intermediate risk? Now, the first answer seemed to come from Soka in her famous review from 2008. Which basically showed a very differentiating picture, where some studies showed a clear benefit and others did not. But especially clear was that the longer the follow-up and the larger the study, the higher the chance that iodine-131 showed a significant effect on recurrence and or mortality. If you look at it, the studies that have a significant result on recurrence and or mortality are also the studies with on average much longer follow-up, 16 years, 10.6, 11, 12. And it is only the smaller study from Toronto that, in spite of having a more than 10 years follow-up, did not show significance for iodine 131. Now, that was 2008. Did anything change? No, it didn't. In the framework of this Smart Me Consensus Conference, a review was commissioned and of the literature since 2008. We did not even endeavor to perform meta-analysis because the data were so inhomogeneous that it would be methodologically incorrect to group them. Now, again, a very differentiated picture. A lot of studies showed no significance. A lot of studies showed significance, especially for the intermediate risk group, also for the lower risk group. But surprisingly, there was even a study which showed a significant favorable effect for microcarcinoma. This is a bit puzzling, but it goes to show that literature still is not in agreement on who should or should not receive radioactive iodine therapy. Now, what is becoming clear is, of course, that whatever study you do, differentiated thyroid cancer takes time to show effects related to radioactive iodine. For instance, in this study from the group of Julian Souza, first author of Rule, it was almost 10 years before you could really see a significant difference between those who received radioiodine and those who did not. And therefore, it is still unclear whether we should give radioactive iodine to low-risk patients. Now, for a number of years, there have been larger trials going on in Britain, the iodine or not trial, and in France, the Estimable 2, both following up the trials which were published some years ago in the New England Journal of Medicine on the low versus high activity. Now, it will be some years, I think, before we get a definitive answer. As just illustrated, you need about 10 years follow-up to be able to make a definitive comment. Now, an important topic related to radioactive iodine is also what to do with the thyrocytes. Thyrocytes require stimulation, they require TSH to function, and therefore it has always been the dogma, or not always, it has been the dogma for the last approximately 40 years that TSH should be high. This is based on a single study in 1978, which showed that patients who were insufficiently operated did not produce sufficient high TSH and were at risk of not having a successful ablation. Now, if you really look at the data, it is interesting to see that in this study from Frahimis, that patients who had a low TSH at ablation after 4 weeks of thyroxine withdrawal actually had a marginally higher success rate of initial radioiodine therapy than those with a very high TSH. However, although Frahimis and colleagues did not show a significant difference in survival, a different picture was seen by Xiao et al. This year in a report on a Chinese population, where they found that those with a TSH below 30 significantly more often had structural indications of disease remaining in the patient than those with 30 to 70 or over 70. So the debate is still out, and professional societies still cannot agree what is the how much TSH stimulation do you need. In the end, it's all about the time TSH curve, and we still don't know whether it's a low TSH for a long time, or a very high TSH, or a very high TSH for a short time, which in the end suffices for stimulation. And thus, there's also some disagreement still, which has not been resolved, with the European side saying that recombinant human TSH is preferred, whereas the American side considers it an acceptable alternative. Now, where does all this heterogeneity come from? It's quite interesting that even though we're treating the same disease, and our patients are not all that different, or quite often, why do we arrive at such different solutions? First of all, of course, between different countries and different circumstances, there are differences in the indication. The European Association of Nuclear Medicine recommends that basically any patient with non-microcarcinoma and without metastases should basically become radioactive iodine therapy, whereas the American population is much more differentiated, with only low risk, with a lot of low risk patients having no definite indication, and a lot of intermediate risks having considering meaning 42% of patients roughly have a consider, where it is left to the physician in his or her preference to determine whether radioactive iodine should be present. Now, this is quite, why this is heterogeneous is illustrated quite nicely by two very prominent thyroid cancer endocrinologists in America, who on the same day to me said, the one said, yeah, it's consider. To me, that means never. And the other one who said, to me, consider means everyone. So this is heterogeneity. This is heterogeneity to the max. Furthermore, it is unclear what the activity does on prognosis. There are many papers saying that 3,700 and 1,100 millicuries are equally effective or equally ineffective, as some said, whereas other papers, such as this one, showed that there might be a difference in activity. So again, there is unclarity there, and that has led to a lot of different dosaging schemes over the course of time. And this difference even holds true in low-risk patients. So there really isn't consensus on what to do. And a third factor is thyroid ultrasound screening. Some countries have thyroid ultrasound screening, Korea, Germany, the United States of America. And it has been well documented here, for instance, in the 2014 New England paper by Arne and colleagues, that the ultrasound thyroid cancer screening leads to a considerable increase in the incidence of papillary thyroid cancer, and but not to an increase in thyroid cancer-related mortality. This is confirmed by studies from Germany, where in both males and females a considerable increase is seen in the incidence of thyroid cancer, but a slight decrease is seen in the death. Now, where does that lead to? An illustration of this is an analysis that we did here in the Erasmus MC using data from one of my from previous papers of mine and the local database here. Now, there's a big difference. Germany has primary care ultrasound screening. The Netherlands has very restricted access to ultrasound only in the second and third line, meaning that patients less often present for analysis of a thyroid nodule. We less often find a small thyroid nodule at a non-clinically dominant stage. And most patients that are treated in the Netherlands are treated because they have symptomatic thyroid cancer, either through lymph node metastases or large nodules. Meaning that you get a different a priori risk profile. As illustrated here, the relationship between tumor diameter and the risk of having a lymph node metastasis is considerably different and considerably more favorable for the patient, for the average patient diagnosed. In Germany, where you have a lot of incidentallomas, compared to the Erasmus and MC, where we only get a higher risk profile. And another factor is the perioperative diagnostics. It is quite known that surgeons will approach thyroidectomy differently when it is known that thyroid cancer is present within the thyroid than when they are doing a goiter reduction. A surgeon will be more radical. A surgeon might be more willing to take to immediately do a lymph node dissection, etc., etc. Now, where does that lead to? If you look at it, a lot of patients still do not have get adequate perioperative diagnostics and have their thyroid removed for other things such as obstructive goiter complaints, cosmetic reasons. And if you compare the groups that had a preoperative diagnosis and intraoperative diagnosis and the diagnosis in the final pathology report, as illustrated in this paper by Ausberger, you actually see that the rate of remission is quite, which you can ascertain after a year, is a lot higher with those who had a preoperative diagnosis than those who had a diagnosis only on the final pathology report. Again, a source of heterogeneity, depending on how many of your patients actually had the diagnosis of thyroid cancer before you actually operate on them. Another contentious issue over the past few years is the risk related to radioactive iodine. As I already illustrated, it has been described as early as 1955 that there might be a relationship between radioactive iodine and especially multiple causes of radioactive iodine therapy and the occurrence of white bone marrow related type cancers. Now, a couple of years ago, there was a bit of discussion related to a paper by Molenaar et al. Now, for all the methodological criticisms that one might have on this paper, there still was a quite clear-cut picture illustrating actually that there was a relationship between an increased incidence of hematological malignancies and giving radioactive iodine. However, if you look carefully at this paper, you can also calculate this risk. For instance, for acute myeloid leukemia, after radioactive iodine therapy and not corrected yet for cumulative activity, it is approximately 1 case per 10 million patient years after radioactive iodine. Now, it is increased, yes, it is statistically significant, yes, but it is also minute. Now, considering that most guidelines foresee that patients who do not receive radioactive iodine have to have more frequent doctor's visits and checkups, this meaning which they usually visit by car, I think that the comparison between the risk of death after radioactive iodine to the risk of dying of driving to the multiple control visits, I think it actually works in favor of radioactive iodine personally. But it might depend on your preference. So personally, therefore, in the light of this, I would personally say use the demon to your advantage. Radioactive iodine might be a demon, but it can still be of good use. And as a last point of attention, as an ongoing discussion and an ongoing point of attention, in more recent years, we have become more aware of the detrimental effects of radioactive iodine on patients, especially on children with pulmonary metastases. This was, for instance, a child from Belarus who got a post-Chernobyl thyroid cancer, which was, as you can see, metastasized heavily to the lungs. And unfortunately, this boy, who was admittedly pre-treated with bleomycin, developed a severe case of pulmonary fibrosis and eventually died. This was the only case out of 200, but still, this is too much. It goes to show that in such cases, you have to be careful. And there are a couple of strategies, of course, that are, you could perform dosimetry to avoid excess exposure to the lungs. You should monitor pulmonary function, and you could consider stopping because even in radioactive iodine refractory pediatric patients from the same Belarusian cohort, it could be shown that once the patients no longer took up or no longer responded to radioactive iodine, that they still showed a decline in thyroglobulin levels and uptake levels on radioactive iodine scans. Once radioactive iodine therapy was ceased and patients were treated on TSH suppressive levothyroxine alone. So therefore, perhaps we should consider stopping. Now, I hope that I've been able to pick some of the more interesting and more contentious topics from current developments surrounding radioactive iodine. But I think it is fair to say that radioactive iodine therapy is an 8-year-old success story, which has gotten the main issues down right from the start. And all we had to do, and all we are still doing, is making incremental small improvements to optimize it further. Now, much more research has gone into differentiated thyroid cancer than into benign disease, and this is in spite of much remaining unclear in benign disease. New is that in benign thyroid disease, finally a clear dose-response relationship has been established through meta-analysis of literature, and I hope that some clarity will come in differentiated thyroid cancer from prospective study results in low-risk patients. Finally, I think it is heterogeneity in all clinical factors surrounding radioactive iodine therapy, which are largely to blame for differences in opinion, differences in strategy for various diseases related to radioactive iodine and its indication and dosage. And with that, I'd like to thank you for your attention. Are there any questions?
Thank you, Erik, for your nice presentation. I see one question in the question box until now.
I can't see the question.
From Marzan.
I don't have the question.
Can you see it?
I don't have the question box. You probably have to make me a presenter again.
Okay.
Or co-host or something like that.
Yes, you still are.
Okay, but the question box has disappeared.
Yeah. Well, I can read it out for you.
That's fine.
Hopefully I pronounce it correctly. What are the indications and contraindications in children and adolescents? Would you prefer it in hyperthyroidism instead of surgery?
This is a very good and interesting question. This nicely connects to the new and upcoming guidelines for the treatment of hyperthyroidism and Graves' disease in children, which are now being finalized by the European Thyroid Association. There's been a fairly clear definition there. Basically, we say that below 5 years, radioactive iodine should not be given. Between 5 and 10 years, radioactive iodine should preferably not be given. And above 10 years or once puberty has started, radioactive iodine can be given without much thought. Now, this sounds rather restrictive, but the same guideline also defines that it is, according to newer insight, it is quite possible and even desired that in younger patients, say if you are between 5 and 10, that you should continue anti-thyroid drugs for a number of years instead of ceasing after a year and then doing definitive therapy. So you can actually postpone the choice for definitive therapy until the patient is 10 and you have all options available. So that would be my answer. I've worked on this guideline, so this is also something I agree with. It will be published shortly in the European Thyroid Journal.
Okay, thank you. So we have a question from Martin Larsson from Karolinska University Hospital in Sweden. Thank you for an interesting talk. I wonder if you could elaborate on how we should define DTC as non-iodine responsive. This is often a clinically tricky question.
It's an extremely tricky question, and Thus far, I have encountered at least 10 different definitions. I'm not going to answer this because right now, between the aforementioned societies, a work group has been formed to actually address this problem and come with a somewhat more uniform set of definitions. So I'm not going to second guess this working group yet.
Okay. Then again, a question from Marzan Rakim Zanova. I have a patient, boy, 10 years old, with lung metastasis, and he got 2 times of radioactive iodine therapy and now following up. What would you recommend in this kind of patient with lung metastasis? How many in total he would be treated with radiation iodine therapy, and what are the future concerns?
Now, this is of course rather difficult seeing and not having seen the images, not having seen the patient, not knowing the thyroglobulin levels, etc., etc. Generally speaking, if thyroglobulin on TSH suppression is fairly low, I think you can safely do nothing, except you have to maintain TSH suppression. I think that is key to everything. If you, as long as you suppress TSH, you have time to make decisions, see what way it goes. Now, if your thyroglobulin on TSH suppression starts rising, of course you have to treat. On the other hand, I would also very carefully monitor pulmonary function in this patient to see whether I have a reserve for treating with radioactive iodine, if at all. So I don't have enough data to give a clear-cut answer. I would say look at all the factors and at least maintain TSH suppressive therapy.
Okay, we've got one more question from Peter Lakwijk. Peter Lakwijk, thank you very much for your lecture. I wanted to ask whether doctors consider the fourth choice of treatment that every patient has, no treatment, wait and see. Is this a step to be considered?
Always. It is always a step to be considered. In fact, it is the prime step to be considered, if you ask me. However, it is never interesting to talk about that in lectures like this. If you're talking about radioiodine, yes, but self-evidently not treating is always an option. And the less life years you have to lose in older patients with differentiated thyroid cancer, in patients with only moderate or mild symptoms of benign thyroid disease. Of course, you should consider just doing nothing. We regularly do nothing in patients who do not have a lot of life years to lose. And the more life years you have to lose, the more serious you have to consider doing something, I think. But in the end, it's always the patient, and you should always respect the patient's wish to do nothing.